Welcome today. My name is Kelly Cox. I'm Director of Support Groups and Senior Director of Regional Community Workshops for the International Myeloma Foundation. You are at one of our regional community workshops, and please get your notepad out and a pencil, and you're going to learn a lot from two outstanding doctors and an outstanding nurse from our Nurse Leadership Board. Next slide, please. Today, we are so grateful to our sponsors, Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Takeda. This program would not be today without their generous sponsorship. Thank you. Next slide. Now, something that's really important to me personally and to the foundation is the feedback. Without feedback from you, whether it's good or bad or needs to be deeper or you got a lot out of it or whatever that feedback is incredibly important to the International Myeloma Foundation in directing what content and what programs we bring to you on a Saturday. Next slide, please. Now, here is the breakdown. You're listening to me. I'm Kelly Cox. The next person who'll be speaking is a dear friend, Rafat Abonour. He'll go into myeloma 101 and frontline therapy. Then we'll have a little question and answer panel. Then we go into meditation and a stretch break. This meditation is done by Kelly Sidorowicz, renowned yoga teacher and so forth, who has helped out a lot of patients with their meditation. Then we go into relapse therapy and clinical trials with Dr. Comenzo, who's at Tufts Medical Center in Boston, Massachusetts. I just like saying Tufts Medical Center. And then Kimberly Noonan, who is with Dana-Farber in Boston. She's on our IMF Nurse Leadership Board, and she'll go into how to manage myeloma symptoms and side effects. So you can see we have a full program today, and I welcome especially the Southeast Virginia support group, SEVA as they call themselves, Norfolk. And we got Stephanie and Brenda, and they have been with this support group since, well, at least Brenda I know, since 2007. And she has done a lot for the patient. And I'd like you to go to the website at myeloma.org, where you can find a whole host of information and see a quilt she's made. It is amazing. My grandmother was a quilt maker, and she did a lot, but her hands got arthritis later on. So the stitches were all over the place, but I still have one of those quilts. So it's a very, very important blanket in our house. So the next slide, I'd like to get this program going, and let's introduce Rafat Abonour, Indiana University, Indianapolis 500, Indiana. Dr. Abonour, please take over.
Good morning, Kelly, and good morning, everyone. Thank you for joining us this morning. The IMF has done an amazing job spreading the word about myeloma and helping the patients dealing with this disease that can be nasty at sometimes. So I'm pleased to talk to you today about, introduction to myeloma, then talk about what do we do when we diagnose myeloma up front. Okay. So I'm going to, bring you back to 1840. The first recognized patient was multiple myeloma. She was having back pain, and she was struggling for a couple of years. And then, they give her bitter infusion for her poor appetite. And 2 years later, she was admitted to St. Thomas Hospital, and she was giving wine, mutton chop, and pint of porter daily, typical hospital diet, yeah? And so what happened? This is what Sarah Newberry looked like in 1844. Her bones are broken, she's emaciated, she had ascites. And then, unfortunately, she did not make it. And the guy who was taking care of her, Sir Solly, did a bone marrow biopsy on her. And I think it was just really insightful is in 1844, before we had all the technology, he kind of recognized the cells, to be oval shape, and thought that the process is inflammatory, thought there was a morbid action of blood vessels. So he was really talking about sort of the pathology of multiple myeloma early on before we had all the technology. So what happened is he did, unfortunately, she didn't make it. And the patient had a biopsy, and this is what he saw, all these ugly looking, what we call them plasma cells. We have these plasma cells. Their job is to make antibody to fight infection. But then one of them become malignant and produce one type of protein. This is just what we call serum protein electrophoresis. Everybody with myeloma will have that test done. And basically what you're looking at the right, there is a spike on the end here. We call that a monoclonal spike, monoclonal protein. And that's really what you go by to diagnose myeloma, because number one is that you want to find the spike. And when the spike goes away, that's a good thing. The myeloma protein is disappearing. And so you don't want to see monoclonal protein once the treatment is started. That's always very important. So what are the major presentation of patients with multiple myeloma? Well, the most common thing is that patients tend to be older. The median age at diagnosis of patient with multiple myeloma is about late 60s, early 70s. A lot of patients will have protein, abnormal protein in the urine or in the blood, and you will find this monoclonal protein. There are 4 things, we call them sort of the CRAB criteria. This is what make the patient symptomatic from myeloma. High calcium in about 20% of the patients, renal kidney failure in about 20% of the patients, anemia in a lot of patients, about 70% of the patient, and bone disease in about 20-25% of the patient. Those are the major sort of presentation of patient with myeloma. So when we do a simple X-ray, this is what we're finding here. It's like these dark spots on the skull or in the arm, in the legs or in the arm. So these, we call them lytic lesion. And these lytic lesions, just like imagine the myeloma cells as like weeds growing in your driveway. You're going to get a hole in the bone, and in that hole, the myeloma cells are growing. It's not a big deal if it's in the skull, but in this guy on the right, the arm, you can see that lytic lesion led to fractures of the arm. So that's major thing with myeloma, is that the bones are fragile and easy to break. Sometimes the myeloma form little tumors. We call them plasmacytoma. These are little collection of myeloma cells. And in this case, for example, on the right, there's a little tumor behind the eye. So we call that a plasmacytoma. Obviously, those can be symptomatic, and they cause trouble. Sometimes the best thing to do for those things is to give little radiation therapy. The problem is that if things are growing in wrong places, like here in this patient's in the spine, you can see there's one of the vertebrae up in the thoracic spine and in the upper back is just broken and sort of pushing on the cord. So you get what we call cord compression. This is urgent. I mean, this is something that the patient will have severe pain. They may have weakness in their legs. So you need to make the diagnosis quickly, treat them quickly, sometimes surgery, sometimes radiation. But it's very important to address that quickly. Some of the new tests that are really very useful are MRIs and PET scans. And I think PET scan is very important. What is a PET scan? You don't take your PET with you to the scanner. We give you sugar that is radioactive, picked up by the tumors. And then we scan you head to toes. And you can see here on the right, the brain likes sugar. So the brain, the head is going to be positive. But what you're seeing here is that sugar, high, radioactivity everywhere else in the bone. So this is a widespread bony disease. And that's very, important, because I think you can diagnose the myeloma that way, but also you can follow the patients. When your treatment is successful, this PET scan should become only positive in the brain and in the bladder area. So it's very important test, and we use it to help us diagnose patient with myeloma. So the other thing is that I didn't have a slide about is that you have to get what we call the bone marrow biopsy to analyze the bone marrow cells for what we call cytogenetic abnormality, chromosome abnormality, I'm sorry. So basically, myeloma can be, good or bad, standard risk or high risk. High risk for short remission, short survival. There are certain chromosomal abnormalities that are not good to have, and that patient need to be monitored much better. Now, not everybody who woke up, one day we'll just have myeloma. Myeloma is preceded by conditions called monoclonal gammopathy of undetermined significance. What does that mean? You have a few abnormal plasma cells in your bone marrow, but they're really not causing you any harm. So the question is, what is the incidence of that? Bob Kyle, one of the most amazing myeloma doctors in the world, who's the father of modern myeloma in America, did a study in Minnesota, near Rochester, where the Mayo Clinic is, and found that probably there is this condition, MUGAS, in about 1% to 3% of the people, and most of these people go on and have a normal life, and the risk of progression is about 1% per year into multiple myeloma. But with modern technology, maybe we can detect more myeloma early on. So the people in Iceland, with the help of the International Myeloma Foundation, started this project. It's called iStop Multiple Myeloma. So Iceland screen, treat, or prevent multiple myeloma. So there really was a very ambitious way to screen a lot of people in Iceland. Iceland is about 300,000 people, and they all genetically been analyzed. So their germline DNA, if they have any predisposition to anything. But we don't know the incidence of MUGAS. So what they did is said, okay, we're gonna offer patients age 40 or older screening. And if we find MUGAS, we're gonna follow them either by the guideline every 3 months or so, don't do anything, or do intensive follow-up. So can people sign up for such a trial? Well, look at that. Between November 2016 and October 2018, they found 148,000 Icelanders eligible to participate. Look, 80,000 people participated. Amazing, 54%. And of those who participated, 75,000 have been sampled. They have sampled on 75,000 people. Well, they found actually 3,725 people with MUGAS, and 237 were known to have MUGAS, and 28 patients were myeloma. So they took those people out, and then they randomized the people to, you don't do anything, follow them every 3 months, or dig in and find if they have something else beside MUGAS. So first of all, I think what they were able to do is, show the people who have more intense workup, they found more things going on, like, maybe a CLL, chronic lymphocytic leukemia, or amyloid, or something like that. So sometimes I think in this case, they showed that you can find more things. The question is that, do you impact the outcome of these people? So it's too early, but I think really this is a first sort of attempt to look at a large population of patients, try to figure out exactly what's going on, and then look at the biology. What makes some of these people develop the myeloma? Is it the immune system? Is it the environment? So I think it's really an amazing step forward to try to understand the biology of pre-myeloma conditions. So I think that was very exciting. So the other study that I really think, it's led by a friend of mine, Dr. Irene Gabriel at Dana-Farber, and it's called the PROMISE study. And I think this is another very ambitious study, and I think it's a very important study. So what is the PROMISE study? It's basically looking at people age 40 and older who have either a family members with multiple myeloma, or they are self-identified as Black. Why are we looking at Black patients, individuals in America? Because the incidence of myeloma among Black has been estimated to be twice as non-Black or non-African American. So the question is, what is really the incidence of pre-myeloma condition in this population of patients? And then, you can start understanding the natural history how you prevent it, why does it happen, and things like that. So I think it's a really very good study. I encourage my patients when I see them to have their family members screen for that. I actually gotten several patients from the study, from the region, who have participated in the study, and they found either they have a MUGUS or a smoldering myeloma. So I think it's, the risk of MUGUS in high-risk population maybe is actually not 1 to 3%, and looks like in some studies at 13 to 17%. And I think with more sensitive assay, we're going to find out maybe more people. The question is what we do about that. I think it's just really understanding what drives the pre-myeloma condition to become myeloma is going to be very important, because then we can prevent myeloma and hopefully understand how we can cure myeloma. So I think that's really very important studies, so I think screening is going to make a huge difference. So let's talk now about, sort of the history of multiple myeloma. I think the problem with multiple myeloma is that for a long time is that, first of all, when I started, and Dr. Comenzo will contest to that, we've been doing this for a while, most patients lived about 2 to 3 years. The good news is that patients are living much longer. And the way, the treatment has improved, because in the old days, we used to say, okay, we're going to do 1 drug or 2 drugs. Now we're looking at, combination therapy to try to eradicate the disease to a level that is undetectable. And the data suggest when you get rid of myeloma, you're going to live longer, you're going to take you longer to relapse. So I think, we need to get rid of these, multiple relapses and becoming refractory, because it's just, I always say to, my fellows is that if you don't get it right the first time or the second time, you're not going to get it right. So you want to give the best treatment for your patients early on, try to get them into remission, try to get them into MRD negative state. So why is that? This is a sort of graph to look at the depth of response. So in the old days, we used to be happy to get rid of 50% of the myeloma. That's called partial response. Well, if you get a partial response, you're leaving a lot of myeloma behind. It's not going to take a long time to grow back to where you started and you become symptomatic. When you get to complete remission, when you don't find a monoclonal protein in the blood and no clonal plasma cells in the bone marrow by the simple assay, that's called complete remission. Still, you have myeloma left behind, and then the patient is going to relapse. I think the success is going to be when you get to what we call minimal residual disease, which means that you look for myeloma cells with very sensitive assay, looking at 1 myeloma cells in 100 cells or in a million cells, and you find no myeloma cells, then you're going to improve the outcome of patient with myeloma. So I think that's really the most important thing you can do, is achieve an MRD negative. This is what the data suggests today. Maybe a prognostic assay to say, okay, you got MRD negative, you're going to do well. But maybe one day we will say, no, we should get MRD for every patient, because that's what's going to make a difference. So we'll see what happens. I think that, there are a lot of studies trying to address that. Okay. So we are going to, the next slide is, what is the mechanism of action of novel agents? I mean, I think the difference now, is that we adding something called antibodies, these proteins that bind to the surface of myeloma cells and try to destroy it. And I think 2 monoclonal antibody that recognize something called CD38 on the surface of myeloma cells are now in the clinic. They've proven to be effective in both the setting of relapse disease and newly diagnosed patients. The other antigen on the myeloma cells, a protein that is very important, SLAMF7, has been shown to be effective with another drug called pomalidomide, or one of these immunomodulatory drugs. And you're going to hear a lot probably from Dr. Comenzo about BCMA as an excellent target that, if you attack that target on myeloma cells, you're going to see a lot of benefit. Okay, so So I'm going to now focus on, I'm going to advance the slide and hopefully it will work. Okay, so upfront therapy. So what do we need to know about upfront therapy? We know that combination therapy continues to prove superiority in providing long remission and long survival. So we're not going to use one or two drugs. We need to use combination therapy. And the good news is that as a patient today with multiple myeloma, guess what? You have a lot of option for induction therapy. And these options should control your disease and provide quality of life and maintain your independence, So you always have the option to discuss the best combination for you up front. So the major combination that continue to be sort of the backbone of every treatment is lenalidomide, bortezomib, and dexamethasone, so the RVD regimen. And now we're looking at combining the monoclonal antibody like daratumumab with lenalidomide for like frail patients. And but I think we have more options. So we're going to discuss some of these advances that have been sort of presented. Okay. We're going to move to the next slide. So what are some of the frontline trials that are really very interesting? They have interesting name, Griffin, Master. There's one from Europe, GMMG HD7. We'll present some of these data. So what is the background? Is that, are we ready for quadruplet, 4 drugs to do an induction treatment before transplant? We already have what we call the DARA-VTD regimen, which is approved in the US, but really we don't use thalidomide a lot in America because of the toxicity. So what is the best 4-drug regimen that we can use? So I'm going to present to you something called the Griffin trial. And this was presented at our last meeting, the American Society of Hematology meeting. Now they have 24 months of maintenance follow-up. So I think that's really very exciting. So what did they do? First of all, they did an induction with 4 cycles. Either you give the standard RVD regimen or you give RVD with the monoclonal antibody daratumumab. And then you do a transplant. And after transplant, you do consolidation with the same regimen you had in the induction for 2 cycles. And then the patient can either maintenance Revlimid or maintenance Dara Revlimid. So, and now we have data on the maintenance part of the trial. So what happened in that after 2 years of maintenance? So let's see what happened. So first of all, look at the, on the left is the group that got daratumumab with Revlimid, Velcade, Dex, and on that's on the left. On the right, only the Revlimid, Velcade, Dex. And look at the, I'm going to show you the last column on each one. I'm going to spend time on that. If you look at stringent complete remission, when you add Dara, it's up to 66%. If you don't, you just using the RVD and then the Revlimid maintenance, you're getting 47%. So clearly the depth of response is superior when you're adding daratumumab to the regimen. All right. So what happened when you try to advance the slide and they don't? Let's look at the MRD negativity. How many patients get MRD negative after 2 years of maintenance? Was 64% in the DARE arm versus 10% in the Revlimid, Velcade, Dex alone. So the 4-drug regimen really led to a much deeper response than the 3-drug regimen. And that has translated to improvement in time without relapse. At 3 years, look at the curve, almost flat, near 100% when you add 4-drug regimen. So I think that's very interesting. I think my conclusion is that the 4-drug regimen had a deeper response than 3, and it deepens at each step, post-induction, post-transplant, post-consolidation, post-maintenance. You're getting more patient getting into the deeper response we like, the MRD negative. And it's feasible. Looks like you can add daratumumab to lenalidomide for maintenance, and there's a trend to improve progression-free survival, time without relapse. So we're getting close, and there are phase 3 studies ongoing to try to address that. What is a phase 3 study? You're trying to compare the 4 to 3 in a very large study. And I think we will have an answer soon. And especially some of these studies, like the ECOG study, trying to direct the treatment based on, are you getting MRD negative or not? So the other study is really called the MASTER study, which I actually like a lot. And it's done by my friend Luciano Costa at University of Alabama. And I call him always Master Costa, because I think this is a masterful approach, because this is really, I think he's one of the people I love, because he is trying to say, we should not be treating the people for the rest of their life. Let's get them into remission. Let's get them into MRD negative. Let's move on. Let's not keep treating people forever. So this is the MASTER study. And what he tried to do is that said, okay, everybody gonna get DARA with carfilzomib or Kyprolis, Revlimid, and Dex for 4 cycles. He's gonna do a stem cell transplant. And after the stem cell transplant, if you are MRD negative, we're gonna stop and we're gonna do surveillance. If you still have myeloma cells, MRD positive, you're gonna get more consolidation and for 4 cycles, and we'll do again, bone marrow, MRD negative, surveillance, MRD positive, another 4 cycle of consolidation. And then finally, after the second consolidation, he will look for minimal residual disease. And if it's negative, surveillance. If it's positive, maintenance Revlimid. So he's trying to guide his therapy based on MRD negativity. So first of all, I mean, I think if you look at patients, whether they were high risk or all patients, when he's getting an amazing number of patients with MRD negative, almost 80%. So clearly it's very powerful regimen and producing a large number of patients achieving minimal residual disease. And it looks like if you have standard risk myeloma or only one high risk for myeloma, such as maybe P17 deletion of chromosome 17, long arm of chromosome 17. Look, I mean, the survival, the progression-free survival, almost flat at near 100%. So I think the trick is going to be the patients, we call them double hit, have very high risk myeloma, 2 or 3 high-risk cytogenetic abnormality. We're still not there yet, but it looks very encouraging in terms of improving time without relapse or survival. So I think this is another, I think, trial to prove that 4-drug regimen and targeting and adjusting the treatment based on MRD negativity in the bone marrow may translate to a long-term survival. Obviously, it's early, but we have, almost a couple of years of follow-up. So I think it's very exciting time. So I think his conclusion is that this is a very feasible study to do MRD, next generation sequencing MRD testing to sort of guide your therapy. I think a large patient have tolerated the treatment fine. And, I think most patients, except the ultra high risk, are benefiting from this treatment. And similar trials are going on to look in a randomized way whether this is a good approach or not. And ECOG is doing sort of similar approach to treating patients with newly diagnosed myeloma. And finally, this is a study presented from the German group looking at another antibody in combination with the standard Revlimid, Velcade, dexamethasone, and monoclonal antibody isatuximab. And again, they randomized the groups to one to get RVD, one to get the antibody isatuximab with Revlimid, Velcade. And what they've shown is that the depth of response based on MRD analysis is superior when you use the 4-drug regimen compared to the 3-drug regimen. And basically, with further follow-up, the depth of response is increasing, the number of patients achieving MRD negativity is increasing, and it looks like it's superior in the 4-drug regimen versus 3-drug regimen. And this is a slide of some of the side effects that you may see, and they look similar, except perhaps there are more decrease in white cells and maybe a slight increase in infection because of the drop in the white count. So, and their conclusion is that this adding the CD38 or VRD or KRD does improve the depth of response in patients. So this is my, I think, last slide. And I think what I'm, I think can conclude for you is that adding monoclonal antibody to VRD or KRD up front is feasible with limited incremental toxicity. The depth of response is improved, including MRD negativity, and MRD will probably be an important measure going forward. A lot of debate whether we should use it as a, Dr. Luciano Costa did in the master study to talk, sort of tune our therapy. There are a lot of trials trying to address that, and I really think it's probably going to be positive. The answer will be yes, maybe you should get MRD negativity. We'll see what happens. I think we still need to work on the ultra high risk patients, but I think the 4-drug regimen, maybe for the average high risk, is very good. I'm not going to talk about transplant, but I think transplant is still important. There was a major study presented at ASCO, the American Society of Clinical Oncology, in a plenary session, suggesting you may not need a transplant up front. I still think that you should have that options available and discuss it carefully with your myeloma specialist. Let me see if I have one more slide. Yes. So this is me with 3 myeloma patients after a bike ride, trying to give it to myeloma. So I think with your help, we're going to try, overcome myeloma. And I really think, the more I see such great results, the more I'm confident we're going to find a cure for myeloma. So with that, I will take questions, Kelly.
Well, what a great topic you picked, you helped us out with. And people out there, I hope your pencils were sharp and your pen had inks. The master trial with Dr. Luciano Costa, great program. The quad trial, I Stop Myeloma, Multiple Myeloma. You can't get this information unless you attend this program. So Dr. Abonour, fantastic presentation, and thank you.
Thank you.
We have some questions, but what I want you guys to do is make sure you go to the audience Q&A, and Robin will start off with some questions that we have from some attendees. Robin, why don't you take the first one?
Hi, sure. Good morning, everyone. Thanks, Dr. Abonour and Kelly. Great informative presentation for Myeloma 101 history, and then all the important frontline therapy for our patients and their care partners to better understand. So one of the questions I see in the box is a really good one. Our patients, as you know, are not always thrilled with getting bone marrow biopsies. So there's a good question in the box about liquid biopsies from regular blood or serum to find the myeloma markers. And what do you think about this and using mass spec during treatment periods?
Really a very important question. Yeah, I mean, who wants to sign for a bone marrow biopsy? Sign up for that. So I think these are two very good assays that may replace the bone marrow biopsy. There are a lot of sort of research going on looking at myeloma cells in the blood. You know, we haven't really validated that yet. And the mass spectrometry is a way to look at the light chain in the blood or the heavy chain in the blood and find it at, you know, first of all, identify it, because, you know, if somebody lambda light chain was 1,000 and now 10, that's good. The number came down, but is the 10 all coming from myeloma plasma cells or normal plasma cells? The mass spectrometry can tell you that, can tell you the difference where that light chain is coming from. So I think both of them are going to be very good, you know, assays or solution to repeating the bone marrow biopsy. But as with every test that comes on the, you know, on the market and it's new, you need to validate that. And I think it's just going to take some time to make to make these sort of part of your routine follow-up. I don't know, Ray, what do you think?
I completely agree with you, Rafat. And as part of the validation, the cell-free DNA or the mass spec test in the blood will need to be correlated with marrow findings. So the validation process itself will require imaging and marrow studies.
Thanks. Robin, you're
muted, Robin. All
so
right.
we have
Okay, here we go.
Go ahead.
I'm looking at the chat box and lots of questions. And I think Master Costa's master study, I really liked that, Dr. Abonour, about should we treat people forever? That is resonating. And so until we get more information from that master study in particular, are there other ways, if people are on maintenance therapy, are there points in time or other ways for patients to have discussions about, you know, do I need to continue to stay on this maintenance therapy?
Yeah, I mean, if you have somebody who's been on maintenance for 4 years and they've been in remission and doing well, and they probably having some side effect of the maintenance therapy, when they come to me, I say, listen, I mean, we have now better assay to see how much myeloma left in your bone marrow. We can do an MRD testing, and if it's negative, and it's been 4 years, probably, you know, we can take a break and watch you carefully. I mean, you know, if I stop somebody's maintenance, I'm going to follow them closely the first year to make sure they stay, you know, in remission without any biochemical relapse, like the appearance of the light chain or the monoclonal protein. So it is possible today to have that discussion. You know, most maintenance trial, the average time on maintenance was 2 to 3 years. So, and there was benefit. You know, translating that to forever, it's hard for me. But, you know, that's, I think, individual sort of approach. Some people feel uncomfortable stopping maintenance, you know. But I think if I have a standard risk myeloma and they've been in remission for a long time and 3 years later on maintenance MRD negative, I probably will have no problem stopping it and watching them carefully.
Okay.
Dr. Comenzo, any thoughts on that?
Yes, I basically agree with Rafat. I think there are many patients who are on maintenance lenalidomide. I have patients who are on maintenance lenalidomide for over a decade now, and they're reluctant to stop. At the same time, it results in one of the most confounding issues that we have to deal with, and that is resistance to lenalidomide. That's a complex clinical issue. But the high-risk folks, I do believe, need to maintain a real careful monitoring process on maintenance because of the nature of the genetic endowment that their myeloma has. The standard risk folks, I completely agree with Rafat on.
Well, thank you. And that's another key point for maybe newly diagnosed patients to really understand and talk to their doctors about high risk, standard risk, and where do they fit in to best talk with their doctors about these treatment decisions. I think the next question may really pertain a little bit more to a future discussion, but we could lead in a little bit with this here. There's talk about CAR T therapy and bispecific therapy. And doctors, I'm sure this is something, especially Dr. Comenzo, I think you'll be discussing a little bit more, but any prelude conversations to that? Like maybe upfront in the frontline therapy, since that's where we're talking right now?
Yeah, I mean, I think Dr. Comenzo will address that. But I think, the question is, CAR T cells going to replace stem cell transplant in especially high-risk patients? There are trials going on trying to test that. So stay tuned. You probably find out that maybe CAR T cells for high-risk myeloma is a better option than transplant. We shall see.
Yes, I agree. And it's important to keep in mind that there are no bispecifics approved for myeloma. They're in clinical trials. There are 2 CAR T cell therapies approved for myeloma, and the data is maturing there, and they're being evaluated, as Rafat suggested, in the context of frontline therapy with an eye towards possibly replacing early transplant.
Pretty exciting thought of the future, and we'll definitely be looking at that. Last question for this session. Are you looking, or is anyone looking at possible triggers that cause an immune system that has been successfully dealing with abnormalities to break down, and then maybe activating or taking someone out of remission?
I wish we know. I mean, I think there's a lot of interest in that, because I do believe that the immune system is so important in controlling residual myeloma after the initial treatment. We, like other centers, we are looking at the bone marrow cells that are not myeloma cells. When we do a bone marrow biopsy, we look at what we call the CD138 negative fracture. So that's not the myeloma population. That's the other population in the bone marrow, with emphasis looking at the immune profile of the patients after transplant, while they are in remission on maintenance, and when they relapse. And our goal is to try to see if there's a difference, what happened when you relapse. You're losing certain population of immune cells that are very important to maintain the remission. And then we'll try to figure out why you lost it. But I don't think we have an answer yet. I don't know. Ray, what do you think?
Once again, I agree, Rafat. We don't have an answer yet, but there is a tremendous amount of interest in the way that the immune system can control cancer. And I suspect we'll benefit from the ongoing studies in that area. At MD Anderson Cancer Center, for example, Jim Allison, who won the Nobel Prize, he was one of the recipients of the Nobel Prize for his discovery of ipilimumab, CTLA-4. They've formed an institute, and they're going to study immunotherapy. And given the myeloma doctors there, I'm sure the myeloma doctors will participate in that. So I think the future is really very exciting with respect to the question that was asked. How can we bolster the immune system to control the myeloma long term?
Okay. I think that wraps up our questions. We're a little ahead of schedule, but that's always nice on a Saturday. Do we want to move forward?
I have a couple of comments here. Can you believe the concept of going from stem cell to CAR T eventually a possibility? I mean, the future is bright. Put on your Ray-Bans. It's something else that's going on. And to even speak about Jim Allison, he's doing some amazing things at MD Anderson. I like their logo. It says, cancer is something, they strike through it. Their attitude is to really do a lot of things there. I think it's Dr. Orlowski is doing work there as well, and he's quite a doctor as well with myeloma. Can you believe what we've heard in the first hour here? I hope you've got something out of it. I've been doing this for 20 years and I still get something out of these meetings. So the next thing we're going to do is take a break. We're going to do a little meditation and a little stretch and go get some coffee. But for now, thank you, and we'll see you on the other end of the break. Meditation and the quiet time. I hope for those that stayed for the meditation and quiet time, I certainly hope you got something from it. I tell you, when I listen to the meditation, I get so chilled. I almost, if I closed my eyes, I wouldn't be here. But that does not happen when we're doing a regional community workshop. I'd like to thank Rafat Abonour, who did a great PowerPoint for 2 topics. But now, as my mom would always say, we're getting into the meat and potatoes of this. So I'd like to introduce you all to Raymond Comenzo. He is at Tufts University, and he's going to go into relapse therapy and the future, the clinical trials. Raymond, take it away.
Kelly, thank you so much. And I must say, the meditation time was great, but your voice is equally great.
Don't fall asleep, people. Just get that piece of paper and a pen, okay? Go ahead, Raymond. Thank you.
Thank you. So these are my disclosures. And as Dr. Abonour indicated, myeloma has periods of remission and periods of relapse. And by convention, we call early relapse the relapses that can occur after 1, 2, or 3 lines of therapy, and later relapses, the relapses that occur beyond that time point. In many, many cases, patients who are young, who undergo induction, stem cell transplant, and then are on maintenance, that period of maintenance and disease control can last for many years. And that's one of the critical aspects that we deal with nowadays, not only in transplant eligible patients, and those are patients usually under the age of 70 or so in the United States, but also in the older folks who've been treated with regimens that contain lenalidomide and then go on lenalidomide maintenance. So that period of remission, that plateau, which we see here, can last for a number of years. As the relapses occur, as a general rule, the period of remission may be shorter, but with the novel therapies we have nowadays, I suspect that is being significantly altered as well. There are criteria that we use to define what we mean when we say that the myeloma has progressed or the myeloma is refractory. So progression requires some numerical increases in a variety of potential measurements. And usually, if someone has an M protein in the blood that we're following, an increase from no M protein to 0.5 grams per deciliter is a definition that's often used, particularly in protocols. The idea of following the chemical measurements of myeloma is extremely important, because if someone is diagnosed with myeloma that's causing bone pain or bone damage and gets into a remission, and the bone pain or bone damage improves and is resolved, you certainly don't want to wait for the patient to get sick again. So the idea of following the chemical measures of myeloma and intervening before the patient gets sick underlies a lot of the thinking with respect to the definition of progression. Primary refractory, on the other hand, means that the myeloma with initial therapy has not responded very well. And those patients whose disease resists 4 cycles or more of 4-drug therapy are patients who probably need a stem cell transplant earlier, even though they're not in deep remissions. That's going to vary from center to center, but historically, that's been a conventional approach. One could also argue that newer medicines may be reasonable choices at that point. However, a lot's going to depend upon what part of the country you're in and what treatments are available at the center where you're a patient. Relapse disease means that the criteria for progressive disease, or PD, have been met, but the patient had originally had a good response, and therefore there's evidence of progression, and that we would call a relapse. Relapsed refractory is the most complicated category, and that's usually the case in patients who've been pretty heavily pretreated, perhaps over a long period, perhaps even a decade, where they've had 4, 5, or 6 different lines of treatment. One of the important things to keep in mind is that if progression occurs within 2 months of starting a new treatment, that really means the myeloma is refractory, and a lot of thought has to go into what the next steps should be. Okay, I've got to refresh my browser again. Okay, there we go. So I'd like to really emphasize the burden of disease, and it varies, obviously. Every single patient needs to be evaluated and have a relationship with the physician that takes these things into consideration. The effectiveness of a care partner or supportive partner is extremely important. The patient's social circumstances, and often that means how far away does the patient live from the myeloma expert who's involved in his or her care. Support within the actual medical practice in terms of navigators, nurse practitioners, and social workers. These supportive individuals can do a lot for patients. I should have included pharmacists. I should have included pharmacists in this list, because there are some expert pharmacists who really know what they're doing when it comes to myeloma medicines and getting patients medicines that their insurance companies may not initially approve. The accessibility of your myeloma doctor and having a second opinion doctor available too, that's an important way to try to deal with the burden of disease. And there are many, many elements within the IMF that are extraordinarily supportive for patients as they deal with myeloma. And one of the important aspects of being a patient is really trying to stay as well as you are once you're in a remission. And that means keeping in mind that it's important to follow up. It's important to get your blood tests and your urine tests done. I actually, in my practice, perform a PET CT annually and a bone marrow study annually on myeloma patients, even those patients who are in very deep remissions, because I believe the disease is smarter than we are. And we have picked up recurrent myeloma on PET imaging in bones and in organs such as the lungs. And that has led us to consider changes in therapy. The genetics of the myeloma are extraordinarily important. About 25% of patients with myeloma have high-risk genetics. That doesn't mean that the disease is not going to respond to therapy. What it does mean is you have to achieve as deep a response as possible in order to prevent progression of the myeloma. And the more effective you are in follow-up, the better you'll be. And obviously, a supportive partner means a great deal in terms of mental health and that push that folks sometimes need to exercise and maintain fitness and bone health. And they're particularly important when those complex decisions need to be made. Well, Rafat has gone over the basics of having a monoclonal protein and a monoclonal spike in the gamma region. And the immunofixation is a more sensitive test. That's the image on the right of the screen, because it can pick up even very small amounts of monoclonal protein. And when the M protein is eliminated from the serum or urine electrophoresis, and it's eliminated from the serum and urine immunofixation, and the light chains are normal, that's a serologic complete response. Now, there may be cells in the bone marrow that are residual myeloma cells, which is why we try to correlate all of these findings. The free light chains are a little confusing, but it's important to keep in mind that the monoclonal protein has two pieces, a big piece called a heavy chain and a small piece called a light chain. And plasma cells in general make extra light chains because the heavy chains can't get out of the cell effectively unless they're paired with light chains. And therefore, even in normals, we can measure circulating free light chains. What the free light chain assay does that's different than the serum protein electrophoresis or immunofixation is that it actually uses monoclonal antibodies against the portion of the light chains that isn't available when the light chains are paired with the heavy chains. So these unexposed areas are exposed in circulating free light chains. And as the table here shows, the frequency with which these serologic, that is blood and urine-based findings are abnormal in monoclonal gammopathies, particularly in myeloma, are listed here, showing that they're pretty sensitive tests. And there is a reason to follow the free light chains, and that is that myeloma cells are smarter than we are, and we have to try every trick in the book to stay on top of the changes that might occur in the multiple clones that comprise a patient's myeloma. There is a phenomenon called light chain escape, when the M protein doesn't change, but the light chains start to climb up because there's a small population of myeloma cells, a subclone, if you will, that is producing only light chains. The risk there with light chain escape is predominantly to the kidneys, because once the serum free light chain level goes up much above 500, there is a risk that the light chains themselves can interact with certain proteins in the tubules of the kidneys and cause kidney damage. So that has to be picked up pretty early in order to be treated to prevent damage to the kidneys as well as to the other organs that myeloma is prone to attacking. So you've seen these pictures before in many cases. The bone marrow contains, on the left, the bone marrow contains sheets of myeloma cells. Occasionally, there's a collection of myeloma cells in a tumor called a plasmacytoma. We do stain the myeloma cells for specific aspects of the proteins, either the light chains, kappa or lambda, or that marker of myeloma, CD138, that is on the outside of the myeloma cells. We also stain for CD38, which is the target for the monoclonal antibodies isatuximab and daratumumab. Rarely myeloma is found in the blood in the form of plasma cell leukemia, but at diagnosis, patients may have a small amount of myeloma circulating in the blood. Bone disease, as Dr. Rafat has gone over in great detail, is a very, very important aspect of the activity of myeloma. And indeed, bone health is very, very important. And that applies particularly to perimenopausal and postmenopausal women. We use a number of different assays. This is a PET CT, which shows a small area of myeloma. This is an MRI, which shows myeloma. Actually, this is a PET as well, which shows myeloma here. And this is an MRI, which shows myeloma in different locations in the spine, as Dr. Abonour described. Next slide, great. So the burden of therapy is also important to keep in mind, and that is that we have extraordinarily effective drugs. However, the drugs have well-described side effects. For example, the proteasome inhibitors, there are 3 of them, bortezomib, carfilzomib, ixazomib, can, to some degree or another, cause peripheral neuropathy, bortezomib being a drug that can cause peripheral neuropathy in perhaps as many as 15 to 25% of patients. If it's picked up early, it's clearly reversible. Ixazomib and carfilzomib are less likely to cause peripheral neuropathy, but they have their own side effects. GI side effects with ixazomib, and with carfilzomib, patients can get rapid heart rate when they're first exposed to it and a spike in their blood pressure. Subsequent exposures are much better tolerated. The immunomodulatory drugs can cause low blood counts. They can cause a risk of blood clots, which is why patients are on aspirin and in some instances on a more aggressive anticoagulants. And chemotherapy as a whole can cause fatigue with these combinations of drugs. Fluid retention and insomnia are often side effects of dexamethasone, a steroid that's widely used. Nowadays, with all of the medicines we have, we still use dexamethasone, but we are very, very agreeable in patients who respond to tapering the dose down and in some instances stopping it altogether, while patients may continue on other drugs. So at the point of relapse, right here, say first, second, or third relapse early on, there is a need for restaging. And that means that imaging, blood and urine tests, bone marrow study, determination of risk based on genetics, standard risk or high risk, and a discussion of options, including clinical trials. Now, the downside of clinical trials, should your doctor recommend a clinical trial, may be that you need a second bone marrow study. Some trials will allow the patient to come in with a bone marrow study that's been done within the prior 6 weeks, for example. But most trials will require a marrow biopsy and aspirate at the time of screening to see if you're eligible for the study. And the critical factors with respect to the burden of therapy, age, fitness, and frailty. We are very attentive to the issue of frailty. I have some 65-year-old patients in my practice who are frail. I have some 75, 77, 78-year-old patients who are quite fit. By definition, patients over the age of 80 are frail. The compliance of the patient. I have patients who actually decide they want to stop their medicine for a while, but don't tell me. So I've got to sit down, I've got to talk in great detail about the risks they're running and encourage them to remain in touch with our practice. Clearly, is this the first relapse? Did you progress on treatment? Is there resistance? Progression on lenalidomide maintenance is actually one of the major issues that we confront. And increasing the dose of lenalidomide probably isn't going to work. Adding dexamethasone to lenalidomide may work for a little while. But it's important to keep in mind the damage that myeloma did at diagnosis and the effectiveness of the prior therapies that the patient was treated with. Other problems clearly play a role. in determining how to treat relapse disease. The presence of peripheral neuropathy, of prior blood clots, whether the patient may have heart or lung disease, kidney and liver function, extraordinarily important, and infection history and vaccination history, also very important. And to determine the resistance to prior medications and the number of lines of prior therapy, those considerations allow us to categorize the patient as in early relapse, 1 to 3 prior lines, or later relapse and possibly relapse refractory. The process of going through induction, transplant, and maintenance is considered 1 line of therapy. It's not 3 lines of therapy. It's important to keep that in mind. And the burden of decision-making, the options that you face when the doctor says, well, you've relapsed again, or here we go again, your disease is coming back, we need to do something. It's important to have these questions available and to have your care partner with you when you have these very complex discussions. Is another stem cell transplant an option? Yes or no? Is a transplant from my twin brother an option if you're lucky enough to have a twin? It's important to understand the phases of clinical research when you start talking about clinical trials. There are phase 3 trials opening now in which a standard combination of 3 medicines is being compared to 2 monoclonal antibodies. There are bispecific antibodies that are in phase 1 trials. So a phase 3 trial means that we're really looking to see whether or not this new combination is better than standard therapy. A phase 1 trial means we're looking to see if this new therapy is tolerated and whether or not we can find the dose that needs to be used in later phase trials. And one of the important things to ask as you review clinical trials, and some of you are going to go to clinicaltrials.gov or go to the IMF website and look at clinical trials, is to ask whether or not you're eligible. Often nurse practitioners can review eligibility with you. So these are important considerations as you look at the menu of clinical trials. When you consider options, one of the key questions is whether or not there's a standard therapy for you. And if your doctor says, I think this clinical trial, it's a phase 1 clinical trial, but I think it's better than standard therapy, ask, why do you think that? What are my options if this new medicine doesn't work? How sick could I get? And sometimes there are going to be really straightforward answers based on the genetics of the myeloma. Your doctor may say, I think myeloma like yours with that genetic endowment is going to be very susceptible to this new drug. Another important thing to keep in mind is that myeloma is a strange disease. Even though you may have progressed on drug X, if indeed a combination of drugs that you may have previously had is available to you, your doctor may want to try that, because sometimes these slowly progressive myelomas in relapse are sensitive to drugs you've been previously exposed to. I've got to refresh my browser again. Oh, excellent. I'm connected to client. So why are there so many options? And it really has to do with the fact that patients are living much longer, as Dr. Abonour indicated, with multiple myeloma, creating populations of patients that the pharmaceutical companies and the FDA can agree on have unmet medical needs. That's one reason. Another reason is all of the science that has gone on at so many centers studying myeloma over the years and the discoveries that have been made. There's a new myeloma center, a serious myeloma center at NYU Langone, based on a philanthropic donation of $75 million, the Perlmutter Center. and there are some brilliant myeloma doctors there. So innovation is the driver, trying to understand the unmet medical needs, the ways that we can attack the myeloma in these different study populations. Also, there are more myeloma experts now. It's a much more interesting area for hematologists to go into. 20 plus years ago, when I moved to New York, to Sloan Kettering, there were no myeloma doctors in New York. I was the only one, basically, at that point in time, and a fellow named Josie McKaylee, who unfortunately was sick. Sundar Jagannath moved to St. Vincent's, and gradually the city attracted a whole bunch of brilliant myeloma doctors. And now there are brilliant myeloma doctors at every major teaching hospital in New York City. There are ethical challenges, though, as clinical research marches on, and those are important aspects that institutions deal with when they evaluate clinical trials for approval. And of course, as the IMF can attest to, there are global challenges with respect to availability of drugs in different parts of the world. And one of the reasons there are so many options available is the IMF and the focus on patients and on their care. Okay, so getting into the meat of things now, as you can see, we can divide the resistance patterns up into len resistant, daratumumab resistant, non-len resistant, and there are options for treatment, combination therapies, usually early on in those early relapses, 1 to 3 lines of prior therapy. One of the preferred treatments is daratumumab, carfilzomib, dexamethasone. Another preferred treatment is carfilzomib, pomalidomide, dexamethasone. So it's often the case that treatment can be customized to the patient once that pattern has been discussed and clarified. And these are treatment options. As you can see, we've lost a couple. We've lost melflufen, and we lost panobinostat because of a combination of things. One being that the panobinostat really wasn't that effective, and melflufen had significant problems with respect to white blood cell counts. But as you can see, there are numerous treatment options that are available to patients. Now, insurance will pay for some or most, but sometimes insurance won't pay for certain combinations. So you've got to deal very effectively with your physician and the pharmacist at your center. And this is the kind of pattern that we deal with. It's another representation. So lenalidomide resistance, here's dara, carfilzomib, dex, dara, pomalidomide, dex. Isatuximab is given IV, dara is given sub-Q. As you can see, this I think is venetoclax, and that would be available to patients who have the 1114 if your insurance company will pay for it. So it's this kind of process that we go through. And here are the kind of risk factors that we would take into consideration, including age, kidney function, a history of low blood counts, a history of peripheral neuropathy or blood clots. Okay, so there is one monoclonal antibody approved for myeloma that carries a cargo with it. It's called belantamab mafodotin. Its brand name is Blenrep. It's directed against that very important protein on the surface of myeloma cells called B-cell maturation antigen. Very interesting protein. It begins to appear on the surface of differentiating B cells as they're heading towards the category of plasma cells. And what's interesting about it is that it's a receptor for certain growth factors, and at the same time, it's shed by the myeloma cells. It's cleaved, and we can measure soluble BCMA. It hasn't gotten to the point where we have that test available to us in the clinical laboratory, but it's actually a useful test in research when we implant myeloma tumors in mice. Blenrep is a very important drug for patients who have resistance to proteasome inhibitors, resistance to IMiDs, that's lenalidomide, pomalidomide, resistance to monoclonal antibodies, daratumumab, isatuximab, because it attacks a different protein on the surface of the myeloma cell, and it delivers a toxic chemo agent, mafidotin, to the myeloma cells. One of the major drawbacks is that about 40% of patients start to get blurring of the vision. So you have to get evaluated by an ophthalmologist before each dose. And we have to hold Blenrep if indeed some blurring of the vision, a syndrome called keratopathy, is appreciated by the ophthalmologic exam. So many patients are reluctant to take the step towards Blenrep, but in some instances, it can be extraordinarily effective even after just a couple of doses. We can stretch out the interval. The normal interval is 3 weeks between doses, but we can stretch it out even longer, and we can reduce the dose in an attempt to maintain the depth of response that the patient has achieved. And as this is a single agent activity here that's really, really extraordinary in the initial trials of Blenrep. And this is a progression-free interval that's also extraordinary. These are all heavily, heavily pretreated patients. Venetoclax, another very important drug, particularly for myeloma patients who have a specific translocation, the 11-14 translocation. That means a piece of chromosome 14 and a piece of chromosome 11 have broken off and they've formed a translocant. And what happens in that setting is that one of the triggers for cell division, cyclin D1, is overexpressed. And in these cases, for the most part, the myeloma cells depend on one protein that prevents them from dying, and that's called B-cell lymphoma 2, BCL2. That protein is called an anti-death or anti-apoptotic protein. And what venetoclax does is it inhibits it. And it can trigger cell death in patients with the 11-14 or patients whose myeloma cells stain for cyclin D1. It's extraordinarily effective if used appropriately, but there was a major setback in a European trial called the Bellini trial. In that trial, patients who got venetoclax, bortezomib, and dex had better progression-free survival than patients who didn't. However, they also had worse overall survival due to infections. And that resulted in the trial being stopped and the FDA being extremely reluctant to construct additional trials in patients with plasma cell diseases. Dr. Kumar, when he analyzed the data from the trial, was able to show that patients with the 11-14 had better progression, had better overall survival than patients without it. And that was a very, very important point to make. Move too fast. CAR T-cell therapy, you've all heard a lot about it. There are two types of CAR T-cell therapy that have been approved for myeloma. And the key here is to understand the process. The process is somewhat complicated. First of all, you do have to have a degree of resistance and possibly be refractory to your last therapy in order to move along to CAR T-cell therapy. Second, most places have waiting lists. So patients have to get on a waiting list. If they're approved for CAR T-cell therapy, they can get some kind of bridging therapy. And then cells are collected, white blood cells. They're sent to a center where they're manufactured into a drug. And the drug is made by putting a genetic vector into those cells that enable those cells to attack the myeloma cells. So the ones that are available for lymphoma have a vector that enable the CAR T cells to attack a protein on the outside of the lymphoma cells called CD19. The ones that are available for myeloma put a vector into the T cells that attack the protein on myeloma cells called BCMA. It is the target for the two approved CAR T cell therapies. They're a little different in terms of how they bind to BCMA, but they're very effective at reducing the myeloma and providing for patients who have complete responses, we think several years of progression-free time. And sometimes you can combine CAR T cell therapy with a subsequent treatment, perhaps even an allogeneic transplant. That's been done with some frequency in the lymphoma world. This is one of the approved products. And as I've explained, there is a delay between approval of the patient for CAR T, collection of the cells, and then the manufacturing process can take up to 3 weeks. The cells are sent back to the center. The patient receives a combination of several medicines that suppress the immune system, allowing the CAR T cells to have free rein to attack the myeloma cells. And the responses are quite high. The second CAR T cell therapy that's been approved, cilta-cel, is also extraordinarily effective, same kind of process, very high response rates, but there are side effects. So one of the side effects is that as the T cells get activated, attacking the myeloma cells, they release a lot of mediators of inflammation and activity called cytokines. And cytokine release syndrome, or CRS, is extremely important. The management of CRS is well described. The grading of CRS is well described. We manage it very effectively. Cartitude, cytokine neurotoxicity, or immune cell associated neurotoxicity syndrome, is also something we watch out for. So in the first couple of weeks after CAR T cell therapy, there may be side effects that do require other interventions to get the patients through these potential side effects. Okay, I'm closing up now by describing the different types of antibodies, and I'm going to describe these bispecific antibodies that are available in clinical trials. One end binds to the myeloma cell, one end binds to the T cell. And BCMA is the new standard target. So CAR T cells, the antibody drug conjugates, and the bispecific antibodies all target BCMA. And CD3 is the marker on T cells that these new antibodies bind to. And teclistamab, Regeneron has a monoclonal, AbbVie, elranatamab, this is a very interesting bispecific. So all of these are available in some form of clinical trial. There also is an interesting antibody drug conjugate that's in clinical trials delivering interferon to the myeloma cells. This is also in phase 1 trials. And how do all of these targets get developed? They get developed because of bone marrow biopsies and aspirates and the identification of proteins on the outside of cells, like this is cyclin D1, CCND1, that are found by immunohistochemical staining. And the future is really, really complicated, but very bright, because we'll have bispecific CAR T cells that will interact with two proteins on the surface. We'll have dual targeted CAR T cells that may use different antibody constructs. And there will be new targets. And that's really, really an area of active investigation at this point in time. Teclistamab is a bispecific developed by Janssen that they're using now in clinical trials in combination with daratumumab. It's been shown to be very safe and surprisingly active. Majestic-1, single agent teclistamab in these heavily pretreated patients, 20% achieve CR. And it's very, very important to be able to show single agent activity. Magnetism-1 trial, another bispecific, elranatamab, in relapsed refractory myeloma. It is also effective. Like teclistamab, there are concerns about CRS and ICANS. And Regeneron has one of these bispecifics too. So what you have to check out at your myeloma center is what may be available. And this is the AbbVie monoclonal, I think, or bispecific. Yeah. And clearly, the response rates were significant, even in patients who were resistant to 3 prior categories of drugs. So we're entering a period of immunotherapy where manipulations can be performed in the laboratory that will allow the immune system to work more effectively targeting myeloma. And these trials are in the future. One final thing, allogeneic CAR T cell therapy is in clinical research as well. The advantage of this kind of CAR T cell therapy is that you don't need to collect the cells and manufacture them and have a delay. You can get the product. But again, these trials are phase 1 trials, trying to identify the side effects and trying to identify an appropriate dose for phase 2. So in conclusion, as I've suggested, the pipeline of new therapies for relapsed refractory myeloma is brimming full. The keys really are age, fitness, and frailty, the presence of other medical conditions, particularly kidney function, liver function, and blood counts, and the profile of side effects that have persisted or that you've had in the past. And one of the key things, as I mentioned, is to ask your doctor if you still have stem cells available. Ask your doctor if allogeneic transplant might be an option for you. And then go over the clinical trials that may be available in your area. One of the key things that I've emphasized to sponsors is that they have to pay for travel and lodging for patients to be treated on their trial. And the majority of sponsors are very agreeable to this. And if you don't have your questions answered, call the IMF. That's what the IMF is there for, to help give you guidance and to help connect you with trials that might be available and might be most beneficial for you and your caregiver to investigate. And at that, I think I'm done. Yeah.
Okay, well, thank you. And thank you for your references to the IMF. I'm a little partial to the foundation. And I do agree with what you're saying. Gosh, I hope everyone wrote it down. This is amazing, amazing clinical trials going on down the road. And you can find that, make it easy. Is it clinicaltrials.gov? You type in myeloma and so forth. I get that kind of confused. But Raymond, that was an excellent presentation of a lot of interesting topics and concepts. So thank you so much. I see Kim nodding her head too. It was really something. Okay.
It was wonderful.
Well, I'm going to introduce another friend of mine, Kim Nguyen, that is on our Nurse Leadership Board. She's at Dana-Farber Cancer Center, and she's on, as I said, on our Nurse Leadership Board. So she's got some great information, and for once, we don't have to rush her too much, and we'll get some questions. We'll go to the questions at the end. So Kim, go ahead and start.
Okay, first I want to start with thanking the IMF. It's really an honor to be here. And after Dr. Comenzo's talk, as well as Dr. Abonour, I just want to say, wow, there's just so many options, as well as there's so much hope, right? So it's just great. And so what we're going to start with is we're going to talk a lot about symptom management, but let's see. So, all right. And so I love this. Life is a canvas, you're the artist, right? And so what does that mean? So Kelly said, you know, get out your pencils, get out your paper. In this situation, get out your brushes, right? Because what I'm here to say is this is very much a science. Myeloma is very much a science, right? But it's also an art. And that's sort of where we're going to focus for the next couple of minutes. And so when you look at, you know, framing your care, you really need to know, about your decision making. You are as much a part of the decision as everybody else on your team. And who is your team, as well as, you know, what are your resources? And we know IMF is a huge resource for us. Who's on your team? And I think, you know, Dr. Comenzo made reference to this. He did a great job in sort of saying, you know, who's your NP, who's your PA, but more importantly, or just as important, who's your myeloma specialist? There's so many and every center that we go to, but also in thinking about, you know, who are the other providers? The pharmacists so they are integral into the care that is provided. What about the RNs? Certainly. And then the oncologists that you're seeing. Who are the specialists and why are you seeing these specialists? And I think that that's a very important part of this. Maybe it's an orthopedic specialist, right? Or maybe it is, a cardiologist. And, who are these people? And know them by name. How do you contact them? These are just very important things to know. And so when we think about, you know, this, and so when we think about the shared decision making, we're looking at the fact that, you know, what's the literature say? We heard a lot about literature from Dr. Comenzo, as well as from Dr. Abonour, that, you know, to say, look at the Griffin trial, for example, you know, look at the DREAM trials. And then you look at that, what is the healthcare professionals recommending to you? And what is your preference? That's just as important as the other three parts. And then in the middle, where, you know, we're looking at, you know, your treatment decisions and your treatment options. Very important part. All right. And so the color wheel of treatment really has to do with, you know, what are the side effects? What are the symptom management? What is my quality of life going to look like on this treatment? All right, and so the gallery of the goals. And when you look at that, what is the myeloma treatment, as well as what is the supportive therapy? When we're thinking about the treatment, what's the rapid and the effective disease control? Some people want that first and foremost, but perhaps you're 94 and you're not really feeling up to, you know, really that very aggressive therapy, as we talked about the frailty scores that Dr. Comenzo talked about. You know, maybe it's lenalidomide and dexamethasone, but, you know, thinking about that and what your preferences are. You want to allow for a quality of life. I often say to patients, you have to look at the therapy that we're giving you. You know, we have recommended this through trials, but what's your body recommending? And it's really all about your quality of life while you're receiving this therapy. And then when you look at the supportive care, look at the preventive disease, the measurements, but also optimize your symptom management. And I'm going to get into that in a little while, but when you think about optimizing your symptom management, really what we're thinking about is, you know, being able and given the time to report what your symptoms are. And I think that, you know, we really can't stress that enough. Okay. All right, and so managing the myeloma, what's the big picture? And we alluded to that in the previous discussions that we talked about, but when you think about it, it really comes into who's transplant eligible, how are we going to treat them, and who's transplant ineligible. So we start off with your initial therapy, and then if you are transplant eligible, obviously you're going to go into a transplant, and then followed by maybe consolidation in many situations. If you look underneath that, the transplant ineligible, very much the same, where we're going to give initial therapy followed by maybe consolidation and then maintenance, right? So what's missing there obviously is the transplant, but then we're going to get into maintenance therapy and then therapy after that, if and when there is a relapse. We talked about situations where, you know, people have been in maintenance therapy for over a decade. I have plenty of patients that are like that. So I think, you know, to be able to make the decision about transplant, it kind of makes sense to spend some time talking about, next slide, talking about, you know, the shades of auto transplant. And in the, you know, we see that, you know, when is a transplant going to be the right time for you? That decision is going to be made with you as well as with your healthcare providers, and, you know, and also your partners, your family are all sort of going to enter into this. So, you know, when you think about that, sort of undergoing the transplant commitment for everybody, I think is important, understanding the process. And so we'll go to the next slide. So when, you know, when is it right for me? And so the current studies, I think it was Dr. Abonour that said there was a plenary presentation by Paul Richardson at ASCO that said, you know, maybe transplant up front was not the way to go, but there's so much data to say that current studies support early auto transplants. Quality of life obviously have to be considered. And I think that one statement that I think everybody would agree on is that allo transplants are not recommended, certainly in the upfront setting. Next slide. Okay, and so here I love this because we are going to do, I guess, transplant by numbers. And so when you look at transplant by numbers, first we're going to look at the eligibility and, you know, who's eligible for this and what is going to be the right time to do a transplant. And then the actual, the second phase is that actual transplant. That's about 3 to 4 weeks. This is when you're going to be obviously receiving the high dose treatment and then the supportive care around that. There's so many transplant centers that are going to this phase in the outpatient setting. And so I know we're gearing up for that, but we'll have to see. Maybe next year we'll be able to present a little bit more information about that. But in the post-transplant setting, that's really where, you know, that's the longest period of time. It's usually 10 to 12 weeks. And it's really re-strengthening and just, you know, reinvigorating yourself. And then from there, we're going to think about maintenance therapy at about 12 weeks. So next slide. And so we just talked about the transplant setting and the transplant phases. I don't think we could do anything without our care partner support, our family support, our significant other support, and friend support. We can't do anything without that. And we need them throughout each phase of treatment for multiple myeloma. And so certainly in that first phase for procedures, but just really having two people sitting in a room, listening to the same information. It's amazing how everybody comes out with maybe a little bit different information or spin on that information. And it's nice to really have like the two people combined, or the family combined to gather that information. Certainly COVID put a damper on that for a while. And I think we're getting back to some normalcy in terms of having people that you need in the room where it's all going to happen. And during phase 2, that's really where we're going to be collecting your stem cells and more information gathering. But people are going to have to help with driving you back and forth to appointments. And in phase 3, the post-transplant phase, it's that continual support and that re-strengthening that is so necessary after a transplant. Next slide. And so we're going to spend a few minutes talking about patient-reported symptoms. So, where have we been? Where are we going? We talked about the fact that as the person and the family that is going through this process, you are very much part of the decision making. You need the literature. You also need facts about symptom management, and you need to have a sense of that symptoms can very much be controlled. And first and foremost, we have to hear from you that there's a symptom. I often have patients really kind of fearful that if they have a symptom, we're going to lower the therapy, and that's going to have a huge impact on the outcome of their disease. And again, so much we can't stress enough that quality of life is so important. When people are on therapy, they're on therapy for a very long period of time. It's important that you lived your optimal life while you're on therapy. So when we think about symptoms, we're thinking about physical symptoms such as fatigue, constipation, peripheral neuropathy. You've all heard them. You've all probably experienced them, certainly in your support groups, if not, unfortunately, individually. Psychologically, with people, there's depression, anxiety, and decrease in cognition function, for example. There's also financial symptoms, and there's financial toxicity that is associated with this. And I think Dr. Comenzo started the conversation, did a great job in bringing this up, and hopefully we'll have some great questions around that at the end. So next slide. So GI symptoms, and it's sort of, for me, it seems to be one of the most prevalent side effects that I deal with, certainly in my practice. So certainly diarrhea on one side, constipation on the other side. If you take too much diarrhea medication, now you're stuck with constipation. And, so it's sort of a titration game, and it's sort of a back and forth kind of discussion. And it must be very frustrating for patients. And so when you think about that, I think the one thing that I'm always saying to patients, and they're probably sick of me saying this, but we really need to think about fluids. If you're constipated, you need to drink more fluids, perhaps. If you have diarrhea, you need to keep up with the amount of fluids that you've lost. And so on the side of diarrhea, what are some of the causes? And we said, maybe you've taken laxatives, but certainly other medications, supplements such as magnesium, antibiotics can cause diarrhea. And so how are we going to treat this? And cholesterol, if it seems to be IMID related, and even when it's not, I've tried cholesterol in that situation, and it seems to be very effective, but Imodium and Lomotil. Dietary changes, often people will say to me, before my transplant, I could eat all the milk and ice cream I wanted, and now all of a sudden I have a sensitivity. So I often ask people to keep a diary, and see if there's something that they can pinpoint in terms of what has changed and why are they having so much GI distress. Certainly, some of our medications that we're treating you with, such as bortezomib or lenalidomide, are going to cause this as well. So, think about it. And sometimes people can identify when they have GI symptoms, whether it's constipation or diarrhea, depending upon when they receive their medication. And maybe they'll have it for 3 days after, and they know they really have to pay attention, during that time frame. So keep a diary. I think that it really, really helps. And then, also be in touch with, maybe through, your EHR, be in touch with your providers to let them know in real time what's going on with you. So constipation, again, often medication provoked some of our therapy that we're giving you, but also pain medications or antidepressants, blood pressure medications, calcium can all cause constipation. And treating it with dietary changes, prunes, people say to me all the time, I just changed my diet and I'm able to really, I'm able to manage these symptoms. But maybe an increase in fiber, whole grains, senna, for example, or Miralax are all ways to do this. But talk about this with your providers. There's so many options for people. So next slide. And so when we think about pain management, there are so many, when we think about the options for that, we could probably spend 3 days and probably a 3-day conference just talking about pain and pain management. It's important for us to know you're having pain, but it's also important for us to know what kind of pain you're having. Is it, pain that it's bone pain? So, that's probably different from neuropathic pain that can be caused from peripheral neuropathy, for example. So that neuropathic pain might be that numbness or maybe that lightning kind of pain that you have, where bone pain is just every time you move, you can feel that pain. And so it's important for us as providers to be able to differentiate the different types of pains that you're experiencing. It may be both. And so we may need a host of medications. There certainly are, pain disciplines, and you can send people to the pain service for interventions for around their pain, but bone strengtheners are very important to decrease bone events such as fractures, right, or big lytic lesions that could be causing discomfort. And so how are we going to treat this? Certainly medication, but also using physical therapy and, surgical interventions. Radiation is another way that we're going to treat pain. And thinking about the complementary therapies. We just did a mind-body experience earlier, which almost put me to sleep, but I woke up and just in time for this, right? And, but acupuncture, yoga, and people really have different experiences with what has worked with them for their pain, and talk about it, keep talking about it. If it's not well managed, keep going with it, because we really, as I said before, want you to live your optimal quality of life. So next slide, and we'll talk about peripheral neuropathy. So peripheral neuropathy is that, we talked about that the proteasome inhibitors, Dr. Comenzo was saying, cause peripheral neuropathy. Lenalidomide can as well. And certainly the disease can, so did you start off with peripheral neuropathy? Was it related to diabetes, for example? And then is it worse with our therapy is sort of the other question. And it's described as maybe numbness or tingling, sensitivity of burning. Maybe it's just muscle weakness. And that description is important as well. So there's preventative ways. Certainly, we know that using sub-Q bortezomib certainly decreased the amount of peripheral neuropathy that people were experiencing. And maybe, putting bortezomib on a different schedule weekly certainly was associated with less peripheral neuropathy. But also, in terms of managing this, vitamin B complexes are often very effective. There's medications that can be used, Cymbalta or gabapentin, pregabalin, as well as I've often sent people to physical therapy or just medication changes, as we alluded to before with bortezomib. But maybe we have to change therapy because this just isn't the drug for you. And that decision is going to be made with your input, as well as the healthcare providers knowing that this is the situation, and something probably needs to be done. Next slide. And so fatigue, anxiety, and depression. And so when I think about fatigue, it says here that 98.9% of all people report fatigue. Well, I think it's about 110. I mean, really, most people are just fatigued. And myeloma, when you think about the symptoms related to the initial diagnosis of myeloma, the number one symptom is fatigue. It's just a difficult thing to work with. I'm sure that you all know that. And it's multifactorial. Is it because of your pain that's causing this? Or is it insomnia because, you're on that super dose of dexamethasone? Is it bone marrow suppression, so anemia from this? Some people say I am the most fatigued when my white count is the lowest. I don't really read a lot about that in the literature, but I certainly hear that from my patients. And so, when you think about anxiety and depression, about greater than 35% report anxiety. And I don't know how it can't be a higher number than that, just based on, everything that you've been through as patients and as family members. Depression as well, about 25% report that. And I certainly can, understand depression, about 25%. I think it's probably a little bit higher than that when, you're faced with things with, relapse and facing more therapy. It's difficult. And so talk about these things, because certainly, we have help. We have people on staff. We have people in the community that really can help you with these feelings. And so with social work, obviously, there's therapists and there's medications if it needs to be utilized. And, exercise certainly is going to help all three of these things. if you are able to do that. So talk about it, make your feelings known. And I think that there really is a lot of help that can be coming your way. And so some of the reasons too, when you're thinking about anxiety and depression, and we're going to get into this, but sort of the financial burden, as well as the disease burden as well. So next slide. And so rest and relaxation contribute to good health. And, it's difficult. I think that if you were somebody that, really at the beginning loved to exercise and loved to do yoga, and, that was you, I think that's great. You're probably going to continue on. But if that wasn't you, you're sort of entering into sort of a whole nother level of being. And it might be a little, difficult to achieve, but easily achievable. And there are really a lot of programs in place, in the setting that you're being cared at, that are in place to help you with this. And so when you think about, the adequate rest and sleep, you think about what's interfering. We talked about steroids, but is it sleep apnea? Is it psychological? You go to sleep, but your brain doesn't go to sleep, right? And so how can we get you there to a better place? And so sleep hygiene is very necessary. Increase your light exposure, for example, during the day often helps. Exercising during the day is huge. And then use your bed only to sleep in, instead of eating and watching TV and looking at your computer, and limit your computer time before you go to sleep, and avoid caffeine and a lot of foods and medications that will keep you awake. Next slide. And so living, and also prevention and living a healthy lifestyle cannot be stressed enough. As you go forward throughout this, we talked about the fragility scores, that the 61-year-old, for example, certainly had a higher fragility score than the 82-year-old. And I think if you just keep up with it, keep exercising, eat the right way, don't gain a lot of weight, all of these things, no matter whether you have myeloma or not, are just cannot be stressed enough, are just very, very important. Try to manage your stress by rest, relaxation, doing that mindful exercise that we saw earlier, which was great. And, maintain a healthy weight. And that's easier said than done when you're on dexamethasone. I agree. And so, preventative healthcare, such as health screenings. Did you do your mammogram? Are your PSAs done? Did you have your colonoscopy? All of these things need to be maintained. I call it baby care, and somebody needs to manage that. So a lot of centers have survivorship clinics. I don't know if yours does, but that may be one area that you might want to investigate. And maintain renal health. I think when people see me, all they see is there's the fluid nurse. That's all I talk about. So for renal health, you want to certainly have enough fluids, and then avoid nephrotoxic medications, but and then to protect your bones. And we talked about, nutrition with that. Calcium, vitamin D is very important. And then bone strengthening agents as well. So next slide. So lastly, and last but not least, is the financial burden. And again, this is another area we could talk about for about, 3 days. And the financial burden really mounts as we go forward. I think Dr. Comenzo was saying that he does an annual PET CT on his patients. And we know that that's just getting more and more difficult to find coverage for that, right? So it is just financial burden is becoming more and more and more of an issue, especially as we have so many more options to treat our patients. And so it might be because of the premiums or the co-pays or maybe the travel expenses. People say to me, just to park here in Boston is very expensive. Never mind coming here day after day after day. And so working with your financial group to really get that covered, working with social services as well. But, the loss of income, and COVID didn't help any of this, right? So lots of issues, multifactorial. But, so I know where I work, we have a very aggressive department called access management, but sometimes that isn't even effective. But certainly working with pharmaceutical, companies and working with people like the IMF is just going to be very advantageous. And so at the end of the day, it's really going to impact the outcome for the myeloma patients and for all of our oncology patients if we don't figure out the financial, if we don't help people with their financial stress over this. So with that, I think we're on to the next slide and I'm done, and we'll open it up for questions. And I really appreciate your time this morning.
Is that the next? You are not alone. That's so important to understand. You used to be alone because that was a long time ago, but now you have resources and they're abundant and they're very clear and they help you out. But again, I'm biased to the myeloma IMF. Please come to our website at myeloma.org. After which this program, which I'll go into questions after this, will be on our website Tuesday or Wednesday, and you can take it slower if you missed anything and get some more information out of that. With that being said, let's go to the questions. Robin, do you have a couple?
Hi, Kelly. Yeah, I wanted to just address a couple of preliminary things first. There was a question in the box. Dr. Comenzo wrote on there the importance of contacting the IMF. So I thought I would give a shout out to the IMF info line. And as Kelly says, pick up your pens and pencils. Here's that number, 1-800-452-2873. 2873, by the way, spells cure. Pretty cool number, right? And then also, Kelly, I kind of have a preference for support groups. And I want to give a big shout out again to those that if you are not attending a myeloma support group, these groups are chock full of information and shared experiences and great resources. So go to the IMF website, check out, there's over 150 myeloma specific support groups in the United States, and they are mostly meeting virtually. So it doesn't matter where you live, you can join a support group and keep learning, and learning is the key word here. So with that said, let's go to some questions. Dr. Comenzo, this one goes back to your discussion on clinical trials. Somebody really wants to know the basics of how do you know if you should seek out a clinical trial?
Yeah, that's a very good question. The early relapses, 1 through 3, are relapses that we have fairly defined therapies for, good options. And the discussion of clinical trial options should include phase 3 studies that might be substituting one drug in a combination therapy for another. So early on, you can discuss available phase 3 trials for early relapse. And there may be trials where, for example, 2 monoclonal antibodies are combined in one arm and 2 or 3 drugs are available in the other arm. The later relapses are definitely relapses that require clinical trials discussions. And in the background of this, as Kim indicated in one of her early slides, is your myeloma specialist. She showed Dr. Dury. Well, you know, there are myeloma specialists who can help answer that question based on the information regarding your clinical status. So I do think you need a team. You need a local hematologist oncologist with support staff. You may need other specialists, as Kim suggested, but you should also have a myeloma specialist who's on your team whom you can access when the question of clinical trials is raised.
Okay.
That's such a great point, Dr. Comenzo. And I'm thinking back to when you were talking about history and you mentioned Dr. McKaylee way back in New York when there were not as many myeloma specialists as there are today. In 2000, my husband Michael was diagnosed with myeloma by Dr. McKaylee. And now all the doctors that we're so grateful to have all over the world, especially if you're in the East Coast, New York and Boston and you know, all of these great cancer centers. So where we've progressed and thinking about the combination of who's on your team, if you have a myeloma specialist near you, and then your local hem-onc. If you end up in the ER, your local hem-onc is going to be really important to know what's going on. So I think knowing who your team is and including those great nurses, as Kim talks about the importance of. Kim, and I have a question, we're going to go to you on this one. Let's talk a little bit about, it's not always the myeloma, and you mentioned the importance of having your regular wellness healthcare checkups. Can you talk a little bit more about that? Because it's not the myeloma doctors and nurses that are checking in on those regular things that happen as we get a little older.
Yeah, thank you, Robin. I love this question. I recently just had the opportunity to just talk about survivorship with a group of oncology nurses, right, trying to take the ONS exam. So, but you really, the way that they described this in some of the literature was a model that said, we need your primary care involved, right, and we also need your oncology specialist. So we need a cancer specialist. We need the myeloma person involved. But when it comes to survivorship and getting these things done, you need to work with your primary care as well as probably with your oncologist as well to get some of these things done. But it needs to be done. And I think, we have a survivorship program. So it really is outlined for everybody exactly when they need their next colonoscopy, when they need their mammogram. I know just, for somebody that doesn't have cancer, when I go to my primary care, she tells me exactly what I need to have done. So somebody needs to do it. And I think that that's a little bit of an open discussion, because how often do people go to their primary care and the primary care says, I'm going to leave that up to the oncology setting, right? But I think as part of what we were talking about, who's on your team and who's going to take responsibility for this part of your care is a conversation worth having.
It's always worth having, Kim, right?
Right. Absolutely. Yeah.
So,
and so I think it should be the primary care, but like I said, sometimes it's hands off when you're going to your primary. They're very timid about that, unfortunately, the cancer patients. And so therefore it comes back to the oncologist or maybe a survivorship, group within your setting.
Yeah, and each hand, so to say, each doctor should know what the other is doing, right? So whatever treatment a patient is on, even including herbs and vitamins and all of those things, everybody needs to know, including dentists and eye doctors, right?
Correct. And I think the EHR certainly has helped, but it certainly hasn't cured this problem, that communication of your primary care and your preventative, your preventative health needs to be communicated. But the EHR certainly has helped. But also patients, they're part of the solution too. They can come in and say, I had this done, and this is what it showed. They can give us the report, and we can put that into the EHR. That helps as well.
And Kim, you had a slide that resonated with me about care partners, and it's so important. And I do worry about those that do not have care partners to help them, because just a second set of ears and having those conversations and listening. And Dr. Comenzo, when you were talking about cytokine release and with caregivers needing to be more on top of monitoring things than not, we even talked, there was a question before about not just cytokine release, but the neurotoxicities. Could we talk a little bit more about that?
Sure. We do know that CAR T cells, as they release some of these cytokines, can also change the balance of chemistry in the brain, and patients can become distracted. They can develop seizures. They can develop visual changes, and those sorts of side effects are put under a rubric and are scored. We have a scoring system for them. The use of a number of different drugs can help in that setting, and these side effects usually resolve. But in the setting of CAR T-cell therapy, patients do need to either, depending on the protocol, patients may need to be in the hospital, or they may need to be very close to the hospital in the event that side effects of this type occur. And most of the time, with the newer approaches that we have and the newer drugs that we have and the better scoring systems that we have, these side effects become very, very manageable. And the higher grade of side effects has become much rarer now that we can recognize them more quickly.
Yeah, like you said, the future is complicated but bright. And so I see another question here. You had a slide up, Dr. Comenzo, about an ADC. It was a newer ADC taking interferon, which was an old myeloma drug that was pretty hard to tolerate back in the day. And maybe people don't even remember interferon, but now there's a phase 1 trial using this old drug. Could we talk about that ADC a little bit?
Sure. So this is a drug that has been developed by Takeda, and it binds to I believe it binds to CD38, and brings with it a couple of interferon molecules that are delivered directly to the myeloma cell. The history with interferon is kind of interesting. Going back 30 plus years, it was used and had quite a substantial side effect profile, but it did work at prolonging progression-free survival in those who were able to tolerate it. This is an interesting antibody drug conjugate. I do think 5 years from now, 6 years from now, we are going to have such a large menu of BCMA targeted agents that a lot of effort has to go into stratifying the way these agents will be used. I do know that we're paying now more attention to the percentage of BCMA on the myeloma cells and the percentage of myeloma cells that have BCMA. And there have been a number of ways that the myeloma cells, which I've said are smarter than we are, have escaped BCMA targeted therapies. So the palette to enlarge upon Kim's notion, the palette is multicolored and there are plenty of shades of gray.
Oh, but those shades, they're getting so interesting, right? And when you talk about the bispecifics, you had a slide, Dr. Comenzo. I didn't get a chance to see the whole thing, but it caught my eye. You were talking about the bispecifics, and you had 3 pictures on there. One was a naked with nothing attached, and then 2 more. And it made me think about understanding bispecifics and how is it the BCMA, and now we have other targets, and how interesting and important targets are, right?
Absolutely. So, for example, CD38 is the target of daratumumab and also of isatuximab, 2 monoclonal antibodies that are a little different in terms of where they bind to the CD38 on the outside of the myeloma cells. The BCMA bispecifics bind to another protein on the outside of myeloma cells, the BCMA, and they bring T cells into a close relationship with the myeloma cells so the T cells can do their work and destroy the myeloma cells. So the bispecifics are similar to CAR T cell therapy, except they don't require, their use doesn't require a manufacturing period or things like that. And the side effects of bispecifics are similar to the side effects of CAR T cells. They're not as dramatic as the side effects of CAR T cells have been historically, but they're similar side effects because T cells are getting dragged in, attacking myeloma cells, getting activated, and making cytokines. The interesting thing about bispecifics is that unlike CAR T cells, they can be used multiple times. You can dose escalate. You can start with a low dose and increase the dose, and then you can give them for multiple doses, as opposed to CAR T cells, which are usually administered one time. In those cases in which CAR T cells have been administered a second time in lymphoma patients, they work, but not as effectively. The other thing about bispecifics is you can add other drugs. So you can use an anti-CD38 monoclonal and a bispecific together. And that kind of clinical research is ongoing now. And actually, there's a phase 3 trial in which that kind of an approach is used and in early relapse patients who might otherwise get something like carfilzomib, pomalidomide, and dex.
Such important information to stay up to date on. Kim, I'd love to bring you back in to talk a little bit about the nurses on the IMF's Nurse Leadership Board are so involved in writing guidelines to not only help other nurses better understand how to manage all of these symptoms of myeloma, but it also helps patients and caregivers. Could you talk a little bit about some of these guidelines and papers that have been written and where maybe people can find them?
Thank you for bringing in the National Leadership Board. It really, I think, has been around for at least 15 years, right? And so, they are exactly what it says. We are leaders in myeloma. And because of all of the research that's done, we help to identify the needs for patient care, to be able to deliver patient care, as well as for us to be able to educate the public about toxicities and about really up-to-date therapies for myeloma patients. And so it has just been an honor to be part of this group for about 9 years. And we've had several publications. We have one coming out, I think, in a few months. And we have input into the Myeloma Minute, as you know, and we've lots of slides that we've created for the myeloma patients, as well as for nursing. Every year at ONS, we have an amazing presentation that at least 500 people attend, and we really go over what has been going on in myeloma for 1 year. And you would think, oh, what are we going to talk about this year? And we run out of time every single year. The questions there and people are amazing, and the people that have attended really will say it's the presentation that we go to every year, and they attend year after year after year. So it really has been quite an honor to be part of this group. They are a force. They really are a force, and it's international. We have international representation, but as well as national representation from across the, from all states. And we try to get that. We really do try to hear from all the different regions within the country.
Well, Kim, and we really thank you for being a part of the IMF's Nurse Leadership Board. It's such amazing work that comes out. And if people are looking for more information from the nurses, you can go to myeloma.org. And if you click under, I believe it's our research. If you click under our research, you'll see more about the Nurse Leadership Board, as well as IMF research that's going on within the IMF. And at this point, Mr. Kelly Cox, I would love to turn it back over to you, because I don't see any other questions coming in.
Well, that was a vigorous question period, as it were. We got a lot of good topics in it, as it were. I think that we are ahead of time, which is good for Saturday, huh? Everyone can enjoy the rest of their Saturday. So I'd like to make sure you do one thing that's really important to me. I've said it a couple of times, your feedback survey. Now you've heard a couple more speakers, and it's important that we hear about that. I think their slides are awesome. You guys and Abonour too go over a lot of topics in a short period of time, which again, this will be available on our website. at myeloma.org. You can get whatever you need about myeloma at myeloma.org. And then we have an info line. It's 800-482-CURE. 482-CURE. Is that right, Robin? It's not 452. All right. Thank you to our sponsors. Let me move the screen around here. We got Amgen, we got Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Takeda. This is an IMF production, International Myeloma Foundation production, and you've just experienced a regional community workshop. I'd like to thank everyone that helped me with this presentation. And Robin Toohey, thank you for handling the questions. And of course, out there to the group in Virginia, that's it for today. Thank you so much.